Welcome to The Explainer. Today, we're tackling a concept that's absolutely fundamental to clinical medicine: acid-base balance. You can think of it as a tightrope walk our body performs every single second of every day. And, well, when it goes wrong, the consequences can be incredibly serious.
All right, so here's our game plan. We're going to start with the absolute fundamentals: what pH is and why it matters. Then, we'll dive into the body's really impressive 3 lines of defense. After that, we'll break down the 4 big ways things can go wrong: the metabolic and respiratory disturbances. Then, we'll learn how to put all those clues together to make a diagnosis. And finally, we'll apply all that knowledge to some real-world clinical cases. So, let's start at the very beginning. What is the central concept here? It really all boils down to the body's critical, non-negotiable need to maintain a stable pH. Now, take a look at this scale. You'll notice it's an inverse relationship. As the concentration of hydrogen ions, that's the acid, goes up, the environment becomes more acidic, and the pH value actually goes down. Our body has to operate in this really narrow, slightly alkaline range. It's not a suggestion, it's a requirement.
Okay, these are the numbers you just have to know. The single most important one is that the body must keep its arterial plasma pH at almost exactly 7.40. That corresponds to a hydrogen ion concentration of just 40 nanomoles per liter. I mean, think how tiny that is. If we deviate outside that very narrow range of 7.35 to 7.43, things can get dangerous fast. So the big question is, how does the body actually defend this incredibly delicate balance, especially with all the acid we're constantly producing from just living? Well, let's get into the 3 lines of defense. This image perfectly illustrates the coordinated response. First up, you have the immediate responders, chemical buffers in our body fluids. They act instantly, within seconds. Then, kicking in within minutes, you have the lungs, which act as a rapid regulation system by adjusting our CO2 levels. And finally, you have the kidneys. They're slower, for sure, but they are the most powerful long-term solution because they can actually get rid of the acid for good. Now, let's take a closer look at that first line of defense. Following the numbers here, it all starts with CO2 produced by a cell. That CO2 diffuses into the blood and right into a red blood cell. Inside, an enzyme called carbonic anhydrase instantly converts it to carbonic acid. This stuff is unstable, so it immediately splits into a hydrogen ion, our acid, and a bicarbonate ion. Now, the hemoglobin inside that red blood cell acts like a sponge, soaking up the hydrogen ion to buffer it. And that bicarbonate, it gets swapped out into the plasma in exchange for a chloride ion. At the same time, inside the cell, things like proteins and phosphates are also acting as buffers. Even other metabolic acids, like keto acids, can join the party and release their hydrogen ions into this very same system. It's a beautiful, intricate dance. And this simple equation, this is the key to everything. This is the whole show. On the left, you have carbon dioxide and water. On the right, hydrogen ions and bicarbonate. The system is under amazing physiological control because the lungs are in charge of the CO2 on the left and the kidneys are in charge of the bicarbonate on the right. Control the ingredients and you control the entire balance. So the lungs are our rapid response system. If the body gets too acidic, sensors in the brainstem detect it and immediately stimulate our drive to breathe. We start breathing faster and deeper, which blows off CO2. That pulls our master equation to the left, using up hydrogen ions and raising the pH back toward normal. The opposite happens in alkalosis. We slow our breathing. But there's a built-in safety measure. You can't just stop breathing completely, because the resulting lack of oxygen, hypoxia, will eventually force you to take a breath.
And finally, the kidneys. These are the powerful final arbiters. They excrete hydrogen ions directly into the urine. But there's a catch. Urine itself can't become too acidic. So the kidneys have a clever trick. As you can see here, they combine those free hydrogen ions with other molecules, like hydrogen phosphate or ammonia. This traps the acid as dihydrogen phosphate or ammonium, which can then be safely excreted. This is how the body permanently removes about 1 millimole per kilogram of what we call non-volatile acid every single day.
Okay, so we've seen how the system works perfectly to maintain balance. Now let's explore what happens when it fails, starting with metabolic disorders. The logic here is actually pretty straightforward. First, you look at the H+, or the pH. If you've got an acidosis, a low pH, and you see a low bicarbonate, you're looking at a metabolic acidosis. If you've got an alkalosis, a high pH, and you see a high bicarbonate, then it's metabolic alkalosis. The primary change is all about the bicarbonate. This really shows the cause and effect. In metabolic acidosis, the main problem is low bicarbonate. The lungs compensate, and they do it quickly by increasing ventilation to lower the PCO2. In metabolic alkalosis, the main problem is high bicarbonate. And how does the body compensate? By decreasing ventilation to raise the PCO2, one system trying to fix the other.
So what is this anion gap? It is an absolutely essential tool for figuring out the cause of a metabolic acidosis. Now, it's not something we can measure directly in the blood, it's a calculated value. And it's not a real gap. It just represents all the negatively charged ions, the anions that we don't normally measure, like phosphates, sulfates, and proteins. Calculating it helps us narrow down what's really going on.
This table is your best friend. Notice there are two main categories. A normal anion gap acidosis is usually caused by losing bicarbonate, think diarrhea, which the body then replaces with chloride to maintain electrical balance. An increased anion gap acidosis is different. It's caused by the addition of some new unmeasured acid, like ketones in diabetic ketoacidosis or lactate in lactic acidosis. When you see a patient, the clinical picture is often dominated by whatever is causing the acidosis. But one key sign is Kussmaul's respiration. That's that deep, labored breathing. It's the body's desperate attempt at respiratory compensation. And a special note, if you see a normal anion gap acidosis, think about renal tubular acidosis, or RTA, especially if the urine pH is over 5.5. But the most important point here is management. You have to treat the underlying cause. Just giving bicarbonate to fix the pH is rarely the right move.
Let's trace this flowchart for metabolic alkalosis, which is most often caused by vomiting. First, you're directly losing hydrochloric acid from your stomach. That's obvious, but you're also losing fluid, which leads to volume depletion, and potassium, which leads to hypokalemia. Now, both of those conditions cause the kidneys to increase their H+ secretion, which just makes the alkalosis even worse. It's a vicious cycle that develops and then maintains the problem.
Okay, let's move on. We've talked about metabolic issues, so now we'll look at disorders where the primary problem lies with the lungs. For respiratory disorders, the primary driver is PCO2. It's that simple. In respiratory acidosis, the PCO2 is elevated because of hypoventilation, not breathing enough. In respiratory alkalosis, the PCO2 is decreased because of hyperventilation, breathing too much. The causes can be anything from lung disease like COPD or a sedative overdose to a patient on a mechanical ventilator or even just a panic attack.
You know, it's absolutely critical to tell the difference between acute and chronic respiratory acidosis. If it's acute, say, someone just choked, the kidneys haven't had any time to compensate, so the bicarbonate level is normal and the pH just plummets. But in a chronic state, like someone with COPD, the kidneys have had days, even weeks, to ramp up bicarbonate reabsorption, so in that case, the bicarbonate will be significantly elevated, bringing the pH back towards the normal range, even though the PCO2 is still very high.
Okay, we now have all the individual pieces of the puzzle. Let's put them together into a systematic approach we can use for any patient. Think of this table as your guide to see if the body's response is appropriate. You can literally plug a patient's numbers into these formulas to calculate what the compensation should be. If the actual value doesn't match the prediction, that's a huge red flag that you might be dealing with a mixed acid-base disorder, more than one thing going on at once. Let's walk through this algorithm. You start with the H+, or the pH. Is it an acidosis or an alkalosis? Simple. Then, you look at the PCO2 and the bicarb to find the primary disorder. Which one explains the pH? Next, you examine the other component to assess compensation. Here's a key tip. If it's simple compensation, the PCO2 and the bicarb should be moving in the same direction. If they're moving in opposite directions, you really need to consider a mixed disorder. And finally, always ask yourself, do these numbers actually confirm my clinical diagnosis? Does the story fit? All right, theory's great, but let's apply this algorithm to 4 real clinical cases. Okay, first up, a 65-year-old with COPD. His pH is 7.10, so that's a pretty severe acidosis. The PCO2 is sky high at 11.5, which tells us this is a respiratory problem. But look at the bicarbonate. It's also high. That's the kidneys working overtime to try and compensate for this chronic problem. So the diagnosis is a compensated respiratory acidosis. Here we've got a 17-year-old with chest tightness. Her pH is 7.49. That's high, so it's an alkalosis. The PaCO2 is low at 3.2, which makes it respiratory. Her bicarbonate is normal, so there's no compensation going on. This is an uncompensated respiratory alkalosis, almost certainly from an acute hyperventilation event, like a panic attack.
And that tingling she's feeling, that's from a drop in ionized calcium caused by the alkalosis. Okay, case 3. A 48-year-old who's been vomiting a lot. The pH is high at 7.50, so it's an alkalosis. The bicarbonate is also high at 29, which makes it metabolic. And the PaO-CO2 is just slightly elevated, which tells us there's a small degree of respiratory compensation happening. This is a classic picture for significant vomiting and loss of stomach acid. And for our last case, a 20-year-old with a fever and low blood pressure. This screams sepsis. The pH is 7.13, so it's an acidosis. The bicarbonate is low at 16, making it a metabolic acidosis, likely from a buildup of lactic acid. Now, we'd expect the body to compensate by blowing off CO2, so the PCO2 should be low. But look, it's 7.1, which is high. It's moving in the wrong direction. This tells us we have a mixed disorder, a metabolic acidosis from the sepsis, plus a respiratory acidosis, probably because the patient is getting tired and can't breathe effectively anymore. This is a critical finding. And that brings us to the end of this deep dive. We've seen that what seems like just a simple pH value is actually maintained by this incredibly complex, multi-system physiological orchestra. The crucial takeaway is that only a systematic approach, using the tools we've discussed, can truly unravel the full story and guide the right treatment, especially when a patient is critically ill. Clinical intuition is important, but as that last case showed us, it's just not enough.